Hello, everyone, and welcome to today's AARC webinar. My name's Billy, I'm with Freestone, and I'll be producing today's session. Before we begin, I'd like to run through just a few housekeeping items. First, I'd like to go over the audio options for today's event. In order to listen, you must listen over your computer speakers. If you are viewing the presentation on an iPad or mobile device, you may need to scroll down to see the slides. Next is Q&A. To ask a question today, please feel free to navigate to the Q&A tab at the top side of your screen. You will type your question in the box and hit the submit button to register it. We will be taking time to answer your questions today, so please feel free to ask them at any time. If you are joining from a group, please make sure to have your group leader submit your information to the group attendance tab. If you are applying this program for credit, you will need to select 2 out of the 3 checkpoints that appear throughout the program today. To check the status of your checkpoints or be directed to your education profile, navigate to the credit tab at the top side of your screen. Please note that for checkpoints to appear, you will need to make sure all pop-up blockers are turned off. At the end of today's event, you will return to this tab to submit for credit. If you do not see the option to submit, please refresh your screen. You will be taken through the credit submission process inside the viewer. If you experience technical difficulties, please refresh your browser window. And should you need technical assistance at any point throughout this session, please navigate to the Help tab to find tips, tricks, and contact information for our support team. And with that, we are ready to begin. Please excuse this brief pause as we engage the recording.
Good afternoon. This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Okay. My name is Ariel Berlinski. I will be your moderator today. I am a professor of pediatrics at the University of Arkansas for Medical Sciences. I am a pediatric pulmonologist who also serves as a Cystic Fibrosis Care Center Director and Medical Director for Respiratory Care Services at Arkansas Children's Hospital. And probably the reason why I'm here today is because I am an aerosol researcher based at the Pediatric Aerosol Research Laboratory at Arkansas Children's Research Institute. Today we'll be discussing the paper titled The Impacts of High-Flow Nasal Cannula Device, Nebulizer Type and Placement on Transnasal Aerosol Drug Delivery, an In Vitro Study. Upon completion of this ARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, discuss the implication of the study on patient care. It is just a privilege, and with great pleasure, I'll introduce the presenter today, Mr. Michael McPeck. Michael is a fellow of the ARC. He's an aerosol research scientist in the Pulmonary Mechanics and Aerosol Research Laboratory Division of Pulmonary Critical Care and Sleep Medicine at the University of New York at Stony Brook. Mr. McPeck discloses that his employer, Stony Brook University, holds patents on nebulizer technology licensed to Inspirix, Inc. Mr. McPeck is an employee of the Research Foundation of the State of University of New York and receives no compensation, honoraria, or other financial consideration from any company. I disclose that I'm an employee of the University of Arkansas for Medical Sciences, and I have relationships with the Cystic Fibrosis Foundation, Mylan, National Institute of Health, Therapeutics Development Network, Trudell Medical, Vertex, and the International Pharmaceutical Aerosol Consortium on Regulation and Sciences. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Michael, welcome to the program.
Thank you, Ariel, and good afternoon, everybody. It's an honor to have been asked to participate in this month's JournalCast, and it's a pleasure to share the band with Mr. Berlinski, who I've known for several years. Typically, I run into him at the AARC Open Forum Aerosol sessions or the Cystic Fibrosis Foundation conferences, as well as meetings of ISAM, the International Society for Aerosols and Medicine, not to mention virtually within his many research publications in Respiratory Care Journal and other relevant journals. So I appreciate his help and assistance with this presentation. First order of business, I'd like to acknowledge the authors of this month's JournalCast paper, Dr. Jay Lee and her colleague, Lucas Williams from the Division of Respiratory Care at Rush University in Chicago, and their affiliate colleague from Airgen Pharma, Dr. Jim Fink. They provided us with a compelling look at some of the issues surrounding transnasal pulmonary drug delivery by way of the high-flow nasal cannula. And this paper also teaches us a couple of important lessons about research in aerosol delivery methods, and that is not to make any assumptions. Instead, measure and test to be certain. And that's one of the things that this paper teaches us. So more on that later on. Let's dive in. First of all, the title is really right on the money. It tells us what the paper is all about, and it sets the stage for that which we are about to dive into. So if I can paraphrase it, first of all, this is in vitro, meaning it's a bench study. It's done in the lab under simulated conditions of some sort, and these will be detailed later in the methods section. Secondly, it's specifically about the impact or the influence on aerosol drug delivery of nebulizer type and placement during high-flow nasal cannula therapy. I may end up abbreviating that at some point because it's going to take up a lot of time to say high-flow nasal cannula therapy each time we have to say it. So be on the lookout for any abbreviations that I may throw in there. And third, and maybe most important, this is about a specific route of drug delivery, that which takes place transnasally or through the nose. Now, essentially, aerosol enters into the front of the nose and then out the other end. And the other end, when you're doing an in vitro test bench model, could mean either the hypopharynx, which is above the vocal cords, or it could mean in the trachea, which is below the vocal cords, depending on what kind of model you have established and how it's configured. And there's different model configurations in the literature, so we'll have to pay close attention to the method section later on to see how the authors did this. So basically, it's a study about what I'm going to call for the moment a relatively new approach to giving aerosols. And as we see, it's trying to piggyback them into a spontaneously breathing patient, along with the gas delivery that's being supplied by the high flow system. So that sounds pretty simple, but is it? Well, no, it's really not quite so simple. The nose is a very big challenge. It's a big challenge. The nose is or was designed to keep stuff out of the lungs. And this is the fundamental challenge of doing research in this mode of aerosol therapy. And this paper is going to demonstrate why this research is so important. So now let's start with the introduction section of the paper, which provides some useful background for us. So I bullet listed some of the relevant points that the authors have provided. From my perspective, COVID has probably taught us a few things about the clinical efficacy of high flow therapy because it's being used so much nowadays. And most of you probably know that better than I, because I work mostly in a lab and not at the bedside these days. When COVID is in the rearview mirror someday, hopefully, we'll likely be more eager and better prepared to use high flow therapy and more frequently in other causes of respiratory failure. And a minute or two ago, I called aerosol delivery via high flow a relatively new mode of therapy. It's actually about 14 or 15 years old since it was first described in the literature. So in medical science, I guess you'd call that new. We do know that it's gaining traction, and there's a lot we don't know. In fact, we don't know everything we don't know yet, and we don't know everything quite for certain. And things we need to nail down and confirm and learn how to predict, these are things that we've got to learn. The reason why the world's experiencing a gradual increase in the usage of concomitant aerosol delivery during high flow is on this slide. Dr. Lee also led a study that was published in RC Journal in 2021 describing a worldwide survey of clinical practice in adult ICUs. And 40% of the respondents reporting using mesh nebulizers with their high flow therapy, while 28% use jet nebulizers. So this clearly suggests the use of aerosolized drugs with high flow therapy is definitely a thing. But we're still flying by the seat of our pants on this. There's no overall consensus on the best way to do it. I don't, or even the best device to use, or the best way necessarily to study it on the test bench. I'm not even sure there's a consensus on whether or not we should be doing it in the first place, but we are. And because we are, studies such as this one by Lee and colleagues are going to be important steps towards our eventual better understanding of the procedure and hopefully a consensus as to its value and how to do it effectively. So right now, there's a lot we don't know or fully understand. And research of this caliber that we're going to learn about today and beyond is certainly going to be welcome. Now, as far as the background literature, there's a fairly hefty amount. I've said that it's not exhaustive, but it is out there. The authors have cited, and they briefly discuss a few of the papers that are relevant to their study, and also serve to demonstrate some of the different techniques that have been published to try to assess aerosol delivery by high flow. For example, drug mass collected at the cannula prongs in vitro on the test bench. Tests like this tend to show the output of the nebulizer and maybe the aerosol transit through the system, but they don't demonstrate breathing pattern effects. You know, the nose is not involved. There's also in vivo scintigraphy or gamma camera imaging in healthy volunteers. These have been done, and they tend to show distribution and deposition of aerosol in the lung. But they don't give you the entire picture. And these types of studies are more powerful when they're used in conjunction with bench studies that tend to make a prediction on aerosol delivery. And then the in vivo portion of the study follows that up to see what happens. So keep an eye out for those kind of studies. There's also been a study in COPD patients where they've measured urinary salbutamol or albuterol excretion. And this demonstrates that aerosol was inhaled into the lung. It was obviously absorbed and metabolized and excreted, but it really doesn't tell us much about the delivery system. It's more qualitative than quantitative, but nevertheless, those kind of tests have been done and they're published. And most of the studies in the literature compare nebulizer types at a single flow and breathing pattern. And so I think we're going to see some deviation from that past pattern in the literature now because it makes sense. Let me back up one slide here. I got a little footnote down there on the bottom. That's what that foot means. I mentioned there's also some retrospective reviews of patient data in the literature. The problem with them is they don't really give you much detail about the delivery system because they're going back and looking at clinical outcomes and that sort of thing. And the people that tend to do these sorts of studies, they're not lab rats and they don't understand the delivery systems, and all that information doesn't make it into these kind of retrospective patient reviews. And one more footnote. I went through my archives on my computer, and the oldest high flow paper regarding aerosol delivery that I could find was dated 2008. It was an interesting and diverse paper from Children's Hospital of the University of Pittsburgh, and it goes back to 2008. And I won't swear to it, but I think that might be the earliest paper in the literature. So now, let me get my slides straight. Where am I? Oh, here we are. Okay, this is where we're supposed to be. So now things weren't complicated enough with the two different nebulizers, and I'm sorry, I have jumped ahead. Let me get back where I want to be. Okay, folks, this is where I want to be. This is part of the background. If things weren't complicated enough with the two different nebulizers and humidifier heaters, two different Airvo circuits, the F&P Airvo humidifier system for high flow, were definitely different, especially with respect to their internal diameters. So the new air spiral circuit design up in the upper left-hand corner of that figure has an internal diameter of 13 millimeters, which is about 47% less than the cross-sectional area of the traditional circuit's 19 millimeter internal diameter, which is 214% greater than the Airvo Air Spiral. So, and the Airvo Air Spiral inner surface has been pointed out as being smooth rather than corrugated. So the study is going to see whether any of that makes a difference. And why should we care about the internal diameter of the circuit? Well, I've rearranged Poiseuille's law, which I finally learned how to pronounce on YouTube correctly after all of these years. And you see part of the numerator is radius of the tube raised to the fourth power. So that means that small changes in the internal diameter of the tubing, and therefore the radius, are likely to have very large effects on the amount of flow that can be accommodated for a given pressure drop. We know this already from our experience: bigger diameter, more flow; smaller diameter, less flow. So we're going to see how that translates into aerosol delivery. Another thing in the background that's put out in the paper is that it appears convenient to attach a nebulizer to the inlet into the cannula. But it's also convenient to attach it directly to the humidifier, and that's something that we've learned on the ventilator side. A long time ago, it was naively assumed that the closer you place the nebulizer to the patient, the better the aerosol delivery will be. But thanks to many folks challenging that assumption and doing quality bench work, we found that notion to be false. So we're going to see how that notion plays out in this particular study. Research papers may or may not be so blunt to state our hypothesis is. Instead, they often beat around the bush a little bit, and they propose a number of reasons why they're doing the study that they did. And this is an example of that. And I have to agree with all of these points. These are all good reasons to do this study. But they also did bluntly state a hypothesis, basically that inhaled dose or drug delivery would be greater with the vibrating mesh nebulizer at the humidifier rather than the nasal cannula. And they also went out on a limb and said there'd be no differences between the circuits. And I took that to mean the differences in aerosol delivery between the three different circuits that would be studied would be negligible. So we're going to get into the methods section and see what they did to try to determine this. I won't spend a lot of time on this. These are some useful criteria that are often suggested for critically analyzing a research study, particularly an in vivo study with human subjects. I'm just going to skip over that and go straight to this. I've kind of jerry-rigged that list a little bit to talk about useful criteria for when you do a bench study, an in vitro study. Instead of including or excluding different types of patients, you often use representative devices. And that's done in this paper, as you'll see, with nebulizers and also with humidifier tubing. And oftentimes those different devices represent the control group. And as far as sample size, these investigators did three replicates for each set of conditions that they studied. And that's apropos for in vitro studies because you want to get the number of replicates to make sure your method is sound, and then you usually take the mean of those to report your data. As far as data validity, we oftentimes have to make certain compromises when we do things on the bench. There's always going to be limitations. We could spend the rest of our life doing aerosol studies and we still wouldn't manage to get to all the different permutations that you could theoretically think of. So every study by necessity has certain limitations. Ethical concerns, not usually for bench studies, and I'll skip over the other 2 points in the interest of time. Now, getting right into their method, they used an intubation mannequin, basically, an adult mannequin with anatomically correct upper airway proportions. They said. Not necessarily actual anatomy, but proportions. The mouth was taped, and that was appropriate, I believe, for this type of a study. Breathing simulation was done with a two-chamber Michigan TTL. They drove one chamber by the ventilator. It lifted the chamber that was attached to the trachea of the mannequin, and therefore it inhaled through the mannequin. And that's how the breathing pattern was transmitted all the way up to the nares. They used two different breathing patterns. Once again, it's appropriate to have at least two of everything. because that's going to give you some insight into how and why things turn out the way they do. So a distressed breathing pattern and a quiet breathing pattern, and you can see what they are. And then finally, they are capturing the aerosol, the albuterol aerosol, on a filter, which in this case has been positioned where that yellow circle is in the figure. It looks to me, well, it's definitely in the simulated trachea, and it looks to me like it might be at the level of the carina, even though they don't specifically say. This is not the only way to do this. There are studies that put it at the hypopharynx, and there is absolute right or wrong. This is a perfectly acceptable method. They use two different nebulizers. They used the Misty Max 10 from Care Fusion. It was operated at 8 liters a minute. When they did this, they subtracted the 8 liters a minute. When they were using the SVN, which was putting 8 liters a minute into the circuit, they adjusted the high flow rate down by 8 liters a minute to compensate for that 8 liters a minute from the jet neb. So when they say 40 liters a minute, for example, it was 40, but 32 were going through the humidifier and 8 through the nebulizer. They used a single Aerogen Solo vibrating mesh nebulizer. They didn't say whether either of these nebulizers, the SVN or the VMN, were tested ahead of time. I presume that they were. That's usually a standard procedure. You want to make sure your devices work, and you want to see if their output is consistent with what the specifications are. Nebulizer placement. Basically, there were 3 different options. They put them on the inlet, the dry side of the humidifier, and we're familiar with that when we use the optical system on ventilators. They put it on the outlet or the wet side of the humidifier for the 2 Airvo 2 circuits that were being tested. And the reason for that is the way that system is configured, and you can't really do it any other way. And I think they mentioned that in the text. And then there was also the method where they put the vibrating mesh nebulizer right into the inlet to the nasal cannula. I said for both systems there. I think I take that back. And then they charged the nebulizer, or filled it, with 2.5 milligrams of albuterol for each condition. They used 1 ml with 2.5 milligrams of albuterol in it for the vibrating mesh neb, and they used a 3 ml unit dose, it appears, 2.5 milligrams per 3 ml for the jet neb. And the reason for that, as we all know, is that jet nebs typically only have an output of roughly half their fill volume. They have roughly 50% residual volume and residual mass, and so to get it to work better, you need a little bit more volume. Okay, now the collection filter that we pointed out earlier, when they collected albuterol aerosol on it, then they eluted the albuterol from the filter using hydrochloric acid and ethyl alcohol. And then that was assayed by ultraviolet spectrophotometry, and that allowed them to derive the number of milligrams, or micrograms actually, of albuterol that was captured on the filter. And this in turn allows the calculation of inhaled dose, or something that I tend to call inhaled mass. You'll hear me say that frequently. And basically it's the mass of albuterol captured on the filter, divided by the mass of albuterol in the nebulizer charge. And so clearly, if you capture, let's say, 365 micrograms of albuterol on the filter, 0.365 milligrams, out of that 2.5 milligrams that you put into the nebulizer, that captured amount would be 14.6%. So this is how we derive the inhaled mass or the inhaled dose. It is a percentage of the nebular charge. And by knowing that number, that actually allows you to do studies and determine the actual amount of drug that's on your filter. Now, there's an alternative terminology. Instead of massive albuterol in the filter, you can also say it's the dose on the filter divided by the nominal dose, which is a term that's often used to describe what you put in the nebulizer in the first place. So anyway, moving forward, I made a spreadsheet here that I'm calling a test matrix, and it kind of demonstrates how the researchers organized their thoughts when they planned out all of these experiments with all these different permutations. And I would probably bet, I mean, this is my design here on the screen, but I would probably bet they did something similar to this. They certainly had it on their head, and they either did it on a piece of paper or they had it in a computer, and that helped them organize and plan the experiments. It also helps for presenting and reporting the data, and you'll see that later. And I mentioned earlier they did 3 replicates of each condition that they analyzed, so you can see how to take any one of these situations and make room for doing 3 different tests, so you can get means and standard deviations. So that's a useful technique, and you're going to see how that plays into the results right here. This is one of their results tables, and basically it looks pretty much like the test matrix that I contrived. They're pretty much one and the same. Now, in this table, this shows the data for comparison of the nebulizer positions, both at the cannula and the humidifier. And so that's the far left-hand column. Now, this was done only with the vibrating mesh nebulizer. To do this particular type of test, there was no need to do 2 nebulizers. The vibrating mesh was sufficient. Notice also, there's also 2 different breathing patterns here for each nebulizer placement, quiet and distressed. And there's 4 different high flow flows, 10, 20, 40, and 60 for each of those conditions. And finally, on the columns on the right, you see there's 3 different humidifier and tubing setups. The OptiFlow, the conventional OptiFlow system that we're used to, hang on. The Airvo 2 with the newer circuit, the air spiral circuit, and the Airvo 2 with its conventional circuit that's been around for a while. So my first observation of this data is that overall, if you look at it, you can see that inhaled mass decreases as high flow nasal cannula flow increases. So this is universal for all of the conditions reported here, and it's a nice demonstration of that effect. My second observation is that overall, it appears that the quiet breathing pattern has a slightly decreased inhaled mass compared to the distressed breathing pattern when the nebulizer is located at the nasal cannula. But except for one circumstance, which was the OptiFlow quiet breathing the OptiFlow quiet breathing pattern at 10 liters a minute, it appears that the IM is greater in all conditions when the nebulizer is placed at the humidifier. So I'll tell you right now, you got to spend some time with this table and go over it frequently. There is a lot of useful information in it. Third observation, the OptiFlow circuit, I would say, for the most part, is marginally to significantly better in most, but not quite all, situations when compared to either of the two Airvo circuits. And then finally, my fourth observation, despite the hypothesis that they proposed early on, it appears that there are some differences between circuits. Overall, it looks like the OptiFlow is clearly better, but the Airvo 2 with the new air spiral configuration, the 13 millimeter ID, internal diameter with the smoothbore tubing, seems to have an edge with the conventional Airvo 2 circuit. So there's just a lot of info in here in this table, and it takes a bit of time. So curl up with it and go through it, draw some lines and circle some things, get out a highlighter, and that'll help you understand it. This is table 2, and this essentially compares the two nebulizer technologies against each other, vibrating mesh and small volume. And in this case, the two main conditions are the two different circuits, the OptiFlow and the new air spiral circuit. And the 10 liter per minute flow condition was not tested for reasons mentioned in the paper. Basically, it was too low to get adequate heating going in the circuit, I think is what they said. So they just eliminated it. Doesn't really adversely affect the results not having it. In this case, in this case, I think there's an inverse relationship that you can still see between the nasal cannula flow and the IM, and it's demonstrated uniformly across the board, just like we saw before. And more often than not, the IM for the vibrating mesh nebulizer does exceed the small volume nebulizer, except for a couple of times at higher flows. I'm going to move along because we still have a bit more to cover. Here's the results in graphical form. And the best thing I could say is this is the tabular data that's presented graphically, if that helps you. And so rather than spend time trying to interpret this for you, I would just say that the graphical data is here. And if you tend to do better with graphical data than columns and rows of numbers, then this may help you interpret that data also. All studies tend to have limitations. I mentioned that earlier. There's nothing you can do about it. You can't always account for everything as much as you'd like to. The authors did comment about the limitations of the mannequin. They mentioned that there was only one nebulizer of each type used, and because of that, it doesn't account for possible manufacturing performance variations. They couldn't necessarily quantify the inhaled dose that might be absorbed by nasal membranes in an in vivo study. I'm not actually sure that's necessary because this is showing us not so much was absorbed by the actually transited through the nose. They limited the study to adult parameters with only 2 breathing patterns and 1 cannula size. I think pediatric studies would be designed similarly, and there's no reason that they couldn't be done. Now, I'm going to try to sum this up. So as expected, pretty much, they saw in the in vitro model with the flow rates greater than 10, the inhaled dose was higher with the vibrating mesh placed at the humidifier than placed at the cannula. This was likely expected. It's been shown in other studies, but it's very important that they validated it and confirmed it in these studies, particularly with some of this different equipment. Inhaled mass with the original OptiFlow circuit is better than either of the two new Airvo circuits. And if you remember the hypothesis, it was predicted that no difference would be found between the circuits. But there was a bit of a difference. And again, this shows the value of measuring things rather than making assumptions. The vibrating mesh delivered greater inhaled mass than the small nebulizer, and once again, no surprise there. Nerd factors. I'm not going to go into these, but there's all kinds of other things that could have, would have, should have, might have been done, and different. The point is, you can't do them all in a single study, so you have to pick and choose. But these are other options, let's say, for additional research. My impression about this is a really good, well-conducted study. It's informative and it's educational. To be honest, I've had to read it a couple of times to get through it and to figure it out, but it's got a lot of useful information. I think it's going to help us better understand this evolving mode of therapy. What do the findings mean? I guess you can refer to this later. This is a summary, and the summary is pretty much mentioned in the discussion section of the paper, and then I advise you to go through that discussion section with a fine-tooth comb. What about effect on clinical practice? Well, I think this gives us some information about different kinds of high-flow devices we may have in our fleet. And we might need to understand that aerosol delivery might be better accomplished with one type of device than another. And we might make the necessary arrangements for this. As for a take-home message, I go back to one of the things I started the talk with, and that is we should never make unwarranted assumptions about aerosol delivery. I mean, we can't see those little individual aerosol particles. We only see a cloud. And therefore, if you want to know what it's doing, you've got to test to figure it out. Assume nothing. And I think that this study demonstrates the technical challenges with this particular route of aerosol delivery. And it also gives us hope that we can overcome these technical challenges. And I think in the future, we're going to get much better studies. So I think the authors should be congratulated for their efforts. It's a good study, and I definitely encourage everybody to read it through a couple of times. Now, that's the end of my presentation. I'm going to turn this back to Dr. Berlinski, and he's going to discuss the Go With editorial that was also published about this paper in the same issue of Respiratory Care. Thank you very much. And if you like this video, please be sure to hit the subscribe button.
Thank you, Michael, for this great presentation. As you stated, the paper was accompanied by an editorial by J.L. Sanders and Mike Davis from Indiana University in Indianapolis. Sort of the summary of findings are not different from what you previously described. So I will not restate them. I will, however, focus on a couple of things that they mentioned. Number one, the acknowledgement that this is an in vitro study, and so that I think it is important. And why is this important? So at least I was able to find from my archives 2 studies using radiolabeled aerosols, looking at intrapulmonary deposition of aerosols using heated flow cannula, and they use flows around 30 liters, and their numbers were around 5% or so. So if you look at the numbers here, they did 20 and 40, and probably it is closer to the results that you get to 20 than with 40. That really overstates that. So that's important to address. The second, they had some concerns about intranasal deposition. Well, just they are right. Those 2 studies found about a 20% roughly deposition in the nose and oropharynx. So this is true. They raise questions about safety and local side effects. And this is especially probably important for drugs that have not been formulated to be inhaled because their pH is not appropriate and could be too maybe a very high osmolarity and different things that can have local side effects. They finished their discussion saying that yes, you can do it, but even if you can do it, even if it works, you don't necessarily have to do it. And I'm just gonna, since I have a few more minutes, I would like to address a couple of things, and I think that apply to these and other studies. Number one, so what is the minimal clinically significant difference in output that will make you choose one device over the other or one placement? And we really do not know that. And how much drug do you need? And is it more or better? Not necessarily. For those who have been following this literature, a long time ago, there's a paper on another situation looking at how many puffs of albuterol do you need on a patient who's on mechanical ventilation, and the conclusion was that 4 was as good as get the response that you obtain. So I think that we can deliver more. The question is, do we need more? And maybe it's not a problem if we use a drug like albuterol, but maybe just could be just something different for a drug with a very what is very expensive. And also it depends on where you are. You may be practicing in the United States, or you may be practicing abroad where maybe the resources are more limited. So if you get 5%, maybe if you add more drug on a cheap drug like albuterol, you overcome those limitations and you sort of obtain the same results. In terms of the testing, I think that was thoroughly discussed. In my experience and in my opinion, I think that you should not use a single device, because when you use a single device, your numbers are really tight and probably do not reflect what's a different batch of devices would be in real life. I think that I will probably stop there with my comment, and then just try to address some of the questions between Mike and I, just some of the questions that have been coming through the chat. So there's a question of rain out in the tubing affecting aerosol delivery. Well, there's impaction against the walls of the tubing, and in fact, did not mention that earlier, but if you measure particle size of the aerosols coming out of the circuit, it really it gets pretty close to what you get outside of the prongs of the nasal cannula. The main filtration, so to speak, occurs there. So that's why it's also sometimes you find that if you put the nebulizer right before the cannula, you probably don't get much because you have a lot of impaction that occurs there. When you choose the side where you place it, think about also the practical issues. Will the patient be moving? Will the device remain upright, or will it change positions? So that's about that. Let's see. I work with all trach patients in my hospital. Is it better to place the nebulizer near the trach or closer to the HME? So I'm assuming this is probably an adult hospital, probably not related to this paper. In the pediatric setups, that's probably where most of my expertise is. We just use it near the tracheostomy, and there's data that you probably need to remove the humidifier system to better deliver drug. And I'm not talking now about the modifications that occur with COVID, but I would say in general. Okay, let's see. The amount of drug, so the amount of drug getting to the lower airways decreases with the high flow rate. Yes, that is correct, and that is seen with these and many of the other studies. There's a question about using an airbow. How can we place the nebulizer? So there's an adapter to place the. I'm not sure if it is available now in the States. I haven't seen that, but they had modified the chamber to allow placement of the vibrating mesh nebulizer on the outlet of the humidifier. Remember that the airbow has a proprietary and tubing, so it really cannot be, you cannot put anything between the device and the tubing. You can either put it in the back, and that just came out a few years after the device was already out there, and you can put it before the nasal cannula.
Yeah, I don't think it's available yet. I don't think it's cleared by the FDA here yet, and if I'm wrong about that, I hope someone will message us and let us know if they've seen it. But I don't think it's yet available, but it's on the horizon, I guess.
Yeah, I saw it in Europe, but I did not see it in here. I wanted to rescue the last sentence of the paper that says these findings cannot be extrapolated to other systems or models of different age groups. And I think that this is very important. So if you take another completely system of humidification that doesn't have this type of setup, you cannot extrapolate these findings. And I think that this is important. If you use different cannulas, those findings might not be real. And sometimes if you have failure of the outcome that you're expecting with the drug that is being delivered, maybe it's because the patient is not getting enough drug. there was a question about the mannequin using to simulate. So this is sort of standard of this type of studies, where you use a system that moves air in and out, and you try to use an anatomically correct upper airway, and you sort of place the filter in between. And that's an intrinsic limitation of the in vitro testing. So there's a question, when using a small volume nebulizer, shouldn't it be better to reduce the high flow nasal cannula as low as possible? And yes, so there's a paper published, I think, within 3 or 4 years in respiratory care, where it's in a pediatric ICU, I think, where they were lowering their flows to 4 liters to allow better drug delivery. And this is considering that the patient can tolerate the lower flow for a certain amount of period. But you have to be mindful that if you're using drugs like ibuprostanol or just any of the bronchodilators that are being used off-label, you just don't want to be varying your dose too much. So, and that is a concern when using these drugs through heated flow cannulas.
Let me comment also on that question. The question mentioned reducing the high flow rate to reduce the dilution of delivered medication. And actually, that's not the way it works. When you reduce the total flow rate coming out of the cannula, you have much less turbulence of that aerosol, and more will actually pass through the nose. It's sort of like trying to fill a Coke bottle with a garden hose. If you have it full blast, it's going to splatter all over the place. But if you slow down the flow, you can fill the bottle and you'd have all that splattering. And I think in our lab, we've been able to characterize that somewhat. So that's the reason you reduce the flow rate, if the patient can tolerate it.
There's a question about a wet side versus dry side of the humidifier. And as I guess that for the device that allows you to put it on the dry side, that's the preferred side. If you put it on the wet side, and Mike had a sort of experience with that in another setting, it ended up affecting your sensors, and it ended up not being a good idea. So really, dry side when you can. For the airbo, you have no choice. Well, your choice is to put it between the nasal cannula and the circuit. That will be your choice.
And given those choices, you're better off on the wet side of the humidifier. And in those conditions, it does a reasonably good job.
Well, I think just we're getting to the end of the presentation. I just want to, Mike, thank you again for joining us today. Thanks to all of you who attended today's seminar. I hope you enjoyed the discussion and the conversation. Our upcoming events are on February 22nd, ethical failures and the impact of on medical distrust. And on February 18th, we have a presenter, but I don't see there the title. But just I want you to join us for both events. And thank you very much for staying with us for this hour. I hope you enjoyed as much as I had, and you have a great weekend.
Bye-bye. Thank you.
Great. Thank you so much. Again, we would like to send a big thank you to Ariel and Michael for their excellent presentation. And again, thank you to all of our participants for joining us today and for your great questions. If you are a group participant, please have your group leader submit your information to the group attendance tab so that you can be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This does conclude today's presentation. To submit for credit, please click on the Credit Submission tab. Once finished, you may simply exit out of your browser window. And we all hope you have a great afternoon.